talk. I'll just introduce myself to the group. I am a neonatologist who works in the United States. I live in Baltimore, Maryland, and I work at the Johns Hopkins Children's Center. And I lead our neonatal focus initiative in the NICU. And frankly, we are always learning so much from our PEM colleagues. So it's actually an honor to be able to share a little bit of my world with you. Now, that being said, I don't think you want to hear about premature infants, 23 weekers born for the whole hour. So I've done my best to try to present the information in ways that are relevant, hopefully, to the practice of a PEM physician. And I hope that when we're finished today, you'll appreciate some of the differences when you're approaching a sick neonate, and maybe even consider some of the protocols that now exist in the neonatal world. I have no disclosures. So let's start with a case just to frame our discussion. And hopefully this makes this relevant to your practice. So you have a 6-hour-old infant who comes to the ED after a home birth. And mom describes the baby as looking blue and isn't breathing right. And on your initial assessment, the baby looks term, tachycardic, tachypnic, retracting, and the pulse ox reads in the 70s, and he's a little lethargic. X-ray can't get to you for another 10 minutes. So what are you going to do? I'm going to leave this pretty informal today, so feel free to chime in, raise your hand. I can see the chat, so please feel free to write things in there too. But any thoughts from my PEM folks, even some of my NICU colleagues, what do you want to do next?
I'll jump in. I guess it would be reasonable to offer some oxygen to this infant, try to obtain some more history, understand if there's been any antenatal care. I suppose at this stage, we're going to be considering getting some IV access, and I guess potentially a capillary blood gas might be sensible.
Yeah, I mean, Dave, I think you're kind of capturing everything that we would normally try to work. First is stabilization, right? So working on, I would throw some oxygen on this baby too, at least to start, being thoughtful in terms of, we don't know what the underlying etiology is for this baby. I will get back to this case, but I think the reason why I put this here is because, one, this is a baby, but it's very relevant, I think, and could very well present in your emergency room, I imagine. And also, this is a POCUS talk, so we'll certainly take a look at POCUS as well. But really, I think neonatal resuscitations are sometimes really high stakes and not and can be sometimes low frequency depending on where you are. So the point of the talk is really to give you a framework for how to systematically approach a decompensating neonate when it comes to doing a POCUS evaluation. So I'm gonna quickly review what's out there first. And I think that it's important to know that there are so many different algorithms for bedside assessment of various conditions when it comes to POCUS. It's an alphabet soup of acronyms to go with. I'm going to review some of the alphabet soup, walk through with a focus on the SAFER protocol in neonates, and then bring it together with some cases. Oh, this is a ChatGPT generated image. Okay, so the two most commonly used protocols, I think, in PEM are probably EFAST and RUSH, right? So many of us know that the EFAST protocols were first developed in adults to rapidly identify this free fluid, usually blood, in the setting of trauma. And with the extended version, including thoracic injuries as well. And one of our PEM colleagues, actually, Antonio, I think some of you guys know here, Antonio Riera, actually did publish a paper in 2021 looking at FAST and found that a concerning FAST exam actually has acceptable sensitivity and remains highly specific in pediatric cases of blunt trauma. So, you know, if you have a positive FAST, it's helpful. On the flip side, slightly different is the RUSH exam, right? So it's rapid ultrasound for shock and hypotension. I think I don't necessarily need to explain it to this group who probably practice it, but it's really meant to be used in any patient with undifferentiated hypotension or shock, right? Not just trauma. And the approach usually broken up into an assessment of the pump, the tank, and the pipes to look at what shock physiology you're kind of approaching. So what do we do in babies, though? What do we do in the neonatal world? So one of our protocols that we have in the neonatal world is the SAFER protocol. And SAFER stands for the Sonographic Assessment of Life-Threatening Emergencies Revised. And the revised version really extends to include extrathoracic causes. So the initial SAFE protocol was really intrathoracic, so cardiac and lung. And the revised version added critical cohort, acute abdomen, and intraventricular hemorrhage. But the idea of the protocol was really, you have one probe, you're going to rule in and rule out urgent conditions that are treatable. So organized by order of urgency and priority really given to treatable causes of decompensation. So I put the article title here for anyone who wants to take a look at it. And here's the algorithm portion of the SAFER protocol. And the idea is for this protocol to really be used in an infant who's acutely decompensating without a clear etiology. Now, I know this algorithm looks busy, but I do want to walk you through it. And I think the big pockets to understand is really that they're divided into organ systems. So you're evaluating really the cardiac portion, so contractility, tamponade. You're evaluating lung, so tension, pneumothorax, and pleural effusions that you can do something about. You're moving to the abdomen and aorta. So is there critical coarctation, intestinal perforation, and then really looking at severe intraventricular hemorrhage. Now, you're like, okay, May, you just told me we're looking at treatable causes, but IVH is not necessarily something I'm going to do anything acutely about. It's not treatable exactly, but we can treat it supportively, right? We can't evacuate the intraventricular hemorrhage, but we can treat it supportively. And in the NICU, at least, it sometimes can be helpful to guide counseling for our needs and their families. When I go back to SAFE versus SAFER, the SAFE protocol is the left side of the algorithm, and then the addition and the revised portion is the right side. Okay, now a few things to note about this algorithm. I think my cardiologist would be remiss with me if I didn't say that we are not diagnosing structural congenital heart disease. So we in neonatology in the US, we are not cardiologists and we are not echo trained. So we are, unless you're doing additional training in hemodynamics, for instance, or even additional echo training. But for the neonatologist, for me, for instance, I don't diagnose structural congenital heart disease. And if there's any suggestion for that, I really do need an echo. But the benefit of this paradigm and this framework is that even in the abdominal aorta assessment, it's really the suspicion of coarct and critical aortic occlusion. At minimum, if I suspect it, I can at least start some interventions while I'm waiting for echo. The other aspect of this protocol and framework that I kind of like that's interesting for novices, and especially in our field in neonatology in the US, where we have a lot of newer learners, is that it actually describes the views to use. So if you had this with you, you're like, oh, how do I look at lung sliding again? Okay, anterior chest wall, vertical scan. It just gives you a couple of primers to remind the new learners, like, how do I do these scans? I've actually seen this protocol used as a training algorithm as well during some POCUS sim sessions and even as a consideration for credentialing. So lots of uses outside of even just the acute clinical care. Now, I think I'm remiss if I don't talk about the other protocols in neonates. So now I will focus on the SAFER protocol today, just because it kind of gives me a nice framework to walk down as I present some cases. But there is an analogous neonatal protocol called the crashing neonate. And this was published a year or two after SAFER. SAFER was a single site protocol, while the crashing neonate is actually an international working group that included the SAFER authors. So it's a little bit more comprehensive even. This protocol also focused on evaluation of the 4 vital organs that SAFER does. But it's more flexible. So you can see that the crashing neonate protocol is not one like you go down the list. This one, you start with where you think the most likely pathology is, and then you go back and you do the other systems. So lets you kind of think a little bit more, I feel like sometimes. For I think the more experienced practitioners, or maybe those who are more comfortable with POCUS and are a little bit more facile moving from different organ systems, I think this one is a great kind of framework to use. Okay, but why are you hearing about SAFER if there's already an algorithm that you can use for sick neonates in the ER like Rush? So here, there are a couple of subtle reminders in neonates that are worth keeping in mind and that I think SAFER does a good job. I am curious though, before I keep going, do you guys use Rush in the ER?
Yeah, so I mean, I guess specifically for Rush, it includes the other bits that are a little bit more adult. So that I guess that's obviously where it came from, me, isn't it? But yeah, if we had, you know, a severely unwell patient, we're going to undertake an assessment that includes obviously lungs and to an extent heart, depending on the skill set. And as you say, if it's a trauma, considering free fluid as part of that. So, I mean, we've had 2 cardiac tamponades in the last month alone. Both critical really. So yes, I guess when I think of, you know, high map, I think of obviously including, you know, they talk about the aorta. I've not really looked at many aortas in my time. I know how to, but I don't think, you know, no triple A's. So I think you're right. The ones of us who are using this would be doing a hybrid of a rapid assessment, basically. Does that answer the
Yeah.
question?
Yeah, I think that's really interesting, right? Because part of the reason why I think SAFER works better for us in neonates as opposed to Rush is because SAFER includes some of the more neonatal specific ones. Like, agree, I'm not going to look for aortic dissection or triple A's in my babies, but I am going to look maybe at aortic pulsatility for a suspicion for aortic coarctation. So I think that's the benefit about SAFER. It reminds me of some of these other considerations I have to think about outside of cardiac tamponade pneumothoraces. And then also it's a good reminder that, you know, the baby's congenital heart disease is very much a consideration in neonates, more so than in those older kids. And so really is at the forefront of this framework first. And then also there's a whole organ that's covered in SAFER that is not readily availably assessed in older kids. You don't have a fontanelle to scan through in bigger kids, and SAFER, the key difference is that it does include cranial ultrasound, which is nice and good consideration. Okay, I'm going to walk through a few cases, case stems that are relevant to PEM, and then put them in the like SAFER framework. So feel free to ask questions as we go. Okay, so we'll get back to that very first case at the very end, but we'll start here. So you've got a 18-day-old with fever who's just not acting right. He's fussy, he didn't want to eat yesterday, and today he's not really crying anymore. He's less active, there's hardly any diapers, and mom brings him in and he's lethargic, ill appearing. He's tachycardic, his cap refills like just super delayed. Any thoughts? Are, you know, you guys probably see this pretty frequently, I imagine.
Yeah, we do see this a lot. I'm again happy to jump in. So obviously physiologically things look a wee bit deranged, don't they? But you know, sometimes these babies, even at 18 days, can actually settle down and look much, much better, more, you know, within a couple of hours. Clearly we'd need to then work them up because fever in this age group, you know, unless you're lucky enough to get flu right in the middle of flu season or an obvious bronchiolitis might not be the case. So yeah, I'd probably again you know, want to do the basic workup, and then maybe if things weren't improving, begin to reach for my probe and have a little look at the lungs and etc. etc.
Yeah, agree. And I think that they, in some of this particular case, for example, you kind of reach for your stethoscope, you reach for ultrasound, and the heart sounds are present, but they seem a little distant. You've got some crackles bilaterally, the liver edge is down, and there was a sibling that had a recent viral infection. So like and then the kid starts to get worse. And so we put a probe on, and you end up seeing an image like this. Now, this is not this specific child, I changed the stem a little bit so that it kind of is a little bit more relevant, but this is exactly what we would see. This is the case. But this would be something to consider. Well, I don't know. I feel like this group would know what this is. Do I have to say it or ask?
I don't think you need to say it. I mean, there are some real learners in the group, some weeks actually, so beginners. So don't worry about explaining anything. I don't want to jump in too much either, but yeah, don't worry about explaining things. But this is obviously an unhappy looking heart. I thought this was the direction you're going in. Siblings got enterovirus, no doubt.
Yeah, sibling had hand, foot, and mouth. But essentially kind of a viral, baby has a viral myocarditis and a little bit of pericarditis with an effusion. This particular scan I didn't get to before we tapped the heart. So the baby was actually much sicker, and our referring hospital actually did the tap while we were consulting. So by the time the baby got to us, this was the effusion size. So it was smaller and not causing as much trouble anymore. But for babies, I think the important thing to note is that even like 5 to 10 mLs that are removed can be actually life-saving. And for the early learners, from a pericardial effusion standpoint, I think we all recognize or are taught, right, that it's not the size of the effusion necessarily that's the trouble, it's how quickly it accumulates. And so because it started to accumulate much quicker, the baby got much sicker. This baby and this scan itself, the function actually doesn't look that bad. But I think when I'm in this cardiac section of SAFER as I'm walking down, right, tamponade, yes or no. So this is not tamponade. But I think it is worth mentioning, especially when I look at any cardiac scan, to take a look at function and really be cautious about giving fluid if you think there's any kind of dysfunction involved. If you think it's cardiogenic shock, like please don't give them more like fluid if the heart can't handle it. So I think that's really the benefit of being able to see things on ultrasound, because you can take a look at what that function is. Otherwise, some of our like initial first step may be to give like a bolus of fluid. There is a hand up, so feel free to ask questions.
Yeah, hi. I just have a question actually regarding because in uterine life, the right ventricle is pretty, I guess, dominant in all of this, right? And if looking at that skin itself, I mean, the RV here still has a pretty thick wall. Normally, when we think tamponade, we think about this thin-walled right ventricular system in anybody who functions in a more adult or non-uterine physiology way. How does that work like so early on with tamponade? Is still the RV collapse your most specific setting for tamponade? Or how does it actually work?
The question is also particularly in neonates, right? Because
Yes, in particular in
it's
neonates. Yeah, like very early on.
Yeah, it's actually it's interesting. It's almost like as if I planted you here because I did want to mention, in neonates, the RV size can be different from what you would normally see in the bigger kids and in adults. So typically, I think our teaching is that the RV should be smaller than the LV, right? When you're looking at chamber size. And what's interesting is that in neonates, up until about the first year of life, the RV to LV ratio is actually higher, in that it's like somewhere around 0.8, so that you can actually see an RV that is about the same size as an LV. It should never be bigger than the LV, but it can be a lot bigger than you would expect in a bigger kid. When it comes to tamponade, I think my cardiologist will tell me that tamponade is not an echo diagnosis. And so that's true, right? We have to diagnose it clinically. On POCUS, I often see a variety, and I will need to go back into the literature and look, but sometimes right atrial collapse is another thing that we'll see as well. Probably even more so.
Right atrial collapse is considered the most sensitive sign, right? So I guess the earliest one. No, for me, right? But no, right ventricular collapse is considered the most specific sign thereof. So at least in my words. So that's the reason why I asked. And there is another, I just once had a case. It was a baby that was like 4 days old and had some glottic surgery done for whatever stenosis or something. And they brought the baby. The baby was hypotensive and had, it was again 4-day-old baby. Brought the baby to the ED, and what struck me was that the baby was a hypotensive. The baby had a delayed caprivo, and I could see, in fact, this really big RV, kind of squishing the LV. And I was like, all right, well, how about this is the physiology, like still the neonatal, very early physiology. So I gave the baby 3 boluses of fluid, and the baby was perfectly, the baby was just dehydrated because after surgery, they didn't drink enough. So that was, what drew my attention, that I had a completely opposite of what I expect in adults for like hypovolemia.
Yeah, I
Definitely not
think,
a giant RV.
yeah, I think that's why babies and their hearts are tricky. And I think that's where babies, and when it comes to cardiac focus, why my cardiologists are so careful about making sure that when my cardiologists teach our cardiac focus to my learners, and are very specific about the fact that neonatal hearts are a slightly different being than adult and older kid hearts, because that physiology is different. So we do see larger RVs, not typically as large as what you're describing, but we do see larger RVs than usually compared to the older kids.
Thank you. Sorry.
Okay, so kind of talk through the things I wanted to mention, especially the conversation about the RV size. And some of it is some RV hypertrophy is normal in neonates, and it's almost worrisome if I don't see it in the very beginning, because of that change from like in utero fetal circulation with the high pulmonary pressures to the extrauterine circulation. So very a little bit different physiology for our neonates. Okay, so something we're going to move on to our next case is something that I think I typically see in the delivery room, but is certainly something that I think could present in the emergency room, especially if you're seeing lots of babies that are born outside of the hospital, or also lack of prenatal care. Sometimes you get your surprises. So this particular case, there was a lack of prenatal care, no anatomy ultrasound. But when they do a bedside ultrasound at the very beginning, no, sorry, wrong case. No anatomy ultrasound, so you don't really know. And then the baby is born at a birthing center. They don't cry right away, and there's a lot of grunting that starts around 30 minutes of age. And the birthing center brings the baby to you. I imagine in the emergency room, sometimes they come directly to the NICU, but you see this baby, and this is a really big baby. The baby's very puffy. There's some generalized edema. There's really some decreased breath sounds bilaterally, and the heart sounds are present, but they're distant. And so this baby is someone that I think I would hope that you don't frequently see presenting to you in the ER, but this is a baby that's really hydropic. So I'll give you the punchline for this one. So this is a baby who has hydrops, and that's really abnormal fluid accumulation that's in about at least 2 body compartments. So typically in utero, when we see these babies, they either have a pleural effusion, pericardial effusion, they have ascites, or they have some skin edema. And usually 2 body parts, compartments involved. And really, why do they have hydrops? Kind of a refresher in terms of why it happens. So you can have immune hydrops, you can have RH or ABO incompatibility that causes really severe fetal anemia and then high output cardiac failure. But you can also have other non-immune causes like cardiac, infectious, parvovirus is one, and some metabolic causes. So this baby, for instance, you get an X-ray, it looks like this. And you go down the algorithm, this baby is starting to work harder, is starting to look worse, and you go down your algorithm, there's no tamponade. There is a small pericardial effusion because that's part of the hydrops diagnosis in this particular child, and the function is okay. It's a little hyperdynamic, actually. But then you do a lung ultrasound, and you see this. And you see a lot of, first of all, there's a lot of skin edema normally to get through, but you're seeing this. And this one, it's the lung ultrasound that I'm showing you here. I do love a good lung ultrasound. Okay. So you can see that there is, if we're going down the algorithm, here, lung sliding. There is lung sliding. There's actually a couple of B lines too. And here's the pleural line, and there's your effusion right there. You only catch a sliver of it here. And then this is a different right upper quadrant view where you can see the spine sign here and then this fluid accumulation here. Now, if I did a better job scanning all around, you would see that there was more fluid in this particular child. There's also fluid on the other side of the chest, more so on the right side than the left for some reason here. And because of the increased work of breathing, this baby ended up getting intubated, and because of the significant increased work of breathing and FiO2 requirements, they actually had this fluid tapped and started to do a little bit better at that. So really, worsening pleural effusions can be a reason why these babies are not doing as well. And again, the SAFER protocol is meant to go through cases that you can do something about. So we did something about it, and the baby still had high drops and still had to get evaluated as to why, but at least wasn't needing 100% oxygen and looking like that. Questions about high drops or even pleural effusions? To other cases that might be more. Okay. Now, I did have to put at least one premature infant case here because I'm a neonatologist. And I also really think it's important for us to kind of share some of the more unusual imaging that we see in neonates and in the NICU that maybe you don't get to see in the EM world. So this is a newborn that's at 27 weeks gestation, so quite early. Born precipitously by vaginal delivery, didn't get any prenatal steroids to help with lung development, and ends up getting intubated in the delivery room and brought to the NICU. And on 100% oxygen to maintain their saturations, and you go down the algorithm. This baby doesn't have a tamponade, but you do the lung ultrasound, and this is what you see. And I think that for Dave has seen these images before for the premature infant, but it's so striking how different it is compared to normal lungs. This is a baby that has, this lung at least is really bad surfactant deficiency. So you can see that there are these subpleural consolidations. You can see that your pleural line is like almost obliterated and super not crisp. And you see all this white lung. Is all this surfactant. This is what a RDS infant looks like. Here is kind of further down. So the question does come up like, is this a pneumothorax? Well, this is not a pneumothorax, right? Because the coalescent of B lines really suggests against it. And there is lung sliding. This one looks weird because this baby is actually on a high frequency jet ventilator. So the movement of the pleural line looks different. But you go down your algorithm, it's like, okay, well, this lung doesn't have a pneumothorax. Maybe I just need to give some surfactant to this child. But it's important, and this is always a reminder, this case was always a reminder to me that you have to scan both sides of the chest. And so this is the right side that you saw, and then this is the left side. So on this left side, any thoughts from the team or the group? Anyone feel free to chime in the chat. But definitely, you can say, oh, well, there's a pleural line and there's A lines.
Before I jump in and say how much I love
Right,
this
so maybe
case,
this is
this
the normal
case.
lung.
Oh, yeah, I was gonna let someone jump in. You should let them have a go, and then I'll continue to say how much I love this case, because you're right, I've heard it before. But is anyone feeling brave enough on the call to describe what the images are significantly different, aren't they? And would any of the neonatologists, for example, have an understanding of obviously what pathologies occurred and why?
I have no experience with lung ultrasound, David.
Well, thanks anyway, Ruben.
Is it-
Good for you to come.
Is the tube two-way down, so one lung is occluded and the other one isn't?
Good, not quite. Good thought though. I'll try and. I love this case. May showed me this case a few years ago. I think it's one of the best examples of ultrasound I think I've ever seen, to be honest. So, if May was telling us that the right lung has this
This
organized.
is a pneumothorax.
Oh, giving it
Organized
away, yeah.
meaty.
Pneumothorax, yeah. So May was mentioning that, this right lung's this established RDS where it's got this loss of normal architecture, the normal reverberation artifact from the air lines going down. And she knows probably what this lung looks like because she scanned it a number of times. Now, on the unaffected side, we can clearly see that we've got these air lines, which shows that there's air there. But what we don't really know is that air from a lung? Well, it can't be, because this child's got established RDS and it's got all of these chronic changes like in the right lung. So this child, you're right, is blown a pneumothorax, and we can immediately see that because we've got these air lines inside the lung. We've obviously got minimal pleural movement compared to the right side, where you can see with this oscillation, we've got the pleural is sliding just very, 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 very fast. On the left, all we really can tell us with that is the appearances are completely changed. So we've now got free air. So this can only really be a pneumothorax.
Yeah. Thanks, Dave. Yes. Yes, you've definitely seen this case before, and I do love it. I love it so much. And especially for my neonatology colleagues, RDS to us and for us is a homogeneous disorder, right? It should be seen on both sides. And so this is why this case is so striking, because it should look like RDS on the left side, right here. And because I don't see that, that was a very striking example of why this is pneumothorax. I have hands up. Anyone can go first.
Yeah,
Okay.
so I was wondering, so the left lung,
Mhm.
that's not typical image of a pneumothorax, isn't it?
Well, what is the typical image of a pneumothorax, though? What are you looking for on ultrasound for a pneumothorax?
Well, I don't know. That's why I'm here and that's why I'm asking. But so the existence of A lines and B lines really means that there is some sort of structure there. So you could, in theory, so unless you've got the clinical case in front of you, you probably won't be able just on ultrasound images to say what's what, isn't it?
So, so much of lung ultrasound is artifacts, and so much of it is also piecing together several bits of information and clues. So to your point, so what does normal lung ultrasound look like? So you should have a nice crisp pleural line, and then the reverberation artifact is where you get the A lines. But A lines simply mean air, and so air in the chest or outside of it, really kind of gives you some of those artifacts that you're seeing on lung. In a pneumothorax, there are a couple of things. So one is you should not see any movement of the pleural line. The lung sliding is usually absent. It's not the slam dunk diagnosis. You can have absent lung sliding in a main stem intubation, for instance, if you had a normal lung. But this case here, in this left side, you don't actually see any lung sliding. The other thing that I don't have a clip of, which I wish I did, is you could also drop what we call M mode, which is motion mode, along the line of this lung. And you can see something called the barcode sign. So that's something that could have helped me with this like pneumothorax diagnosis on ultrasound, which if I had the M mode clip, I'd show it to you, but I don't. So M mode barcode sign basically means motion lung. Let's say I drop one line here. And because the lung is not moving, it kind of shows up as a barcode.
The reason I'm asking is because at some point I was in a lecture of someone from France, and they're using lung ultrasound instead of X-ray, and they are actually draining pneumothorax based on the lung ultrasound. So I think the question was, would you go to the left lung and drain it based on the ultrasound images? Do you need anything else?
In this particular case, I would absolutely. If this baby were not doing well and my X-ray was delayed and I saw this lung ultrasound on the right side and then the left side, I would stick a needle in that chest.
Okay, thank you.
And I'll show you the X-ray. This was the X-ray for that baby. And there was a big left-sided pneumothorax that we evacuated and then ultimately put in a chest tube to evacuate the rest of the pneumothorax, and then gave a dose of surfactant as well once the pneumothorax was evacuated.
Thank you.
I see another hand up.
Yeah, sorry, me. Yeah, I echo your thoughts. And I think looking at that picture, in terms of differentiating pneumothorax from anything else, B lines act as a surrogate marker. If you don't see B lines, we can employ the M mode to confirm the pneumothorax.
Yeah, thank you. Okay, so we're going to move away from lung a little bit. Oh, I made one more point to myself. So that was a premature infant case. So for those that are EM on this case, on this talk, you're like, okay, well, that's worthwhile maybe to see what RDS looks like on ultrasound, because we don't see it in the ED, but there could also easily be other cases that present to you that may be similar. So for a pneumothorax. So this one is a amalgamation of cases that we have seen before, whereas a 6-hour-old post-dates 41-weeker born precipitously, they're LGA, they're infant of a diabetic mother, they have meconium fluids that have initial respiratory distress, gets intubated by EMS, and comes to you and there's worsening saturations and the exam has gotten worse and there's no lung sounds on one side. So even just the infant of the diabetic mother and meconium fluids can put you at risk for a pneumothorax as well. So not something you don't see often or potentially see. Okay, I know with time, I want to shift gears a little bit. So this is a case actually of a baby that's in our NICU who's actually doing okay, but did present at 14 days old. Was a 37-week infant, so kind of early term, had a brief NICU stay actually for mild aortic arch hypoplasia, so actually had a coarct rule out, and by the time they were discharged around 7 days of age, the PDA had closed and the arch was only very mildly narrow. So he goes home and he does some feeding with mom and then comes to the ED because he had a large bloody stool and was fussy, and mom's like, he does not look right. You examine him, he's hypothermic, he's lethargic, he's got a distended belly, he's got some decreased femoral pulses, and he's working a little bit harder to breathe. So do I need the safer protocol for this case to tell me he doesn't have a cardiac tamponade? Probably not. I don't think he does, but certainly some abdominal etiology. If this patient presented to you guys on the peds EM side, I think you'd have some pediatric EM diagnoses to work through as a potential. Intussusception kind of comes to mind for me, but I will say I don't see intussusception that frequently.
Malrotation?
Yeah, malrotation
Malrotation.
certainly. Yes, yes, malrotation definitely something to consider as well. Any other things that you guys would throw out there? Now, I'm a neonatologist, so also think preemie or neonatal.
Neck.
Yeah. Yeah, I would think neck as well. I think what puts him at higher risk for neck probably is the fact that he has some mild arch narrowing. So does that put him at increased risk? And he's a late early term infant. He is a little unusual, I will say, because he did end up having necrotizing enterocolitis. His X-ray does show pneumatosis in the bowel wall. This baby in our NICU is actually doing pretty well. He's being treated medically for neck with antibiotics and bowel rest. But in the very beginning, it was probably worth, if I had the wherewithal, to take a look with POCUS just to see what his abdominal aorta looked like. But he did get a repeat echo and his arch is fine. So I wanted to talk a little bit about neck. And the reason why I wanted to talk a little bit about neck is because this is a term infant that did show up in the ED and did end up having necrotizing enterocolitis that got admitted to us. He's also being worked up for a GI bleed. And he, once the neck treatment is done, we'll probably look fully for malrotation, but he did not have malrotation with volvulus, at least no volvulus at the moment. On the other hand, these babies can get really sick really fast. So not this child, but a baby with a similar X-ray over a period of 6 to 8 hours goes from CPAP to intubated and on 2 pressors and lactic acidosis. So these babies can get real sick real fast. And if these kids end up staying in your ER and you're worried about them, maybe it is worth going through the SAFER protocol when they start looking worse. To look to see if there's any cardiac dysfunction, effusions, pneumothoraces, and then really what's worse is if they end up with a perforation. So I'll show you some abdominal ultrasound images of a baby with necrotizing enterocolitis who did get really worse. So this one here, at least, this is what pneumatosis or air in the bowel wall looks like on ultrasound. So this is what we typically see for the neonatologists on the call as pneumatosis. And then this image. This is what we see as portal venous gas. So portal venous gas is air that's in the portal venous system. And you can actually see it on ultrasound as opposed to on X-ray when you see it as just a kind of a tree-like pattern. But more than that, this case in particular, this baby on abdominal ultrasound actually had free fluid and ended up having free fluid in the abdomen. And because of how much worse clinically this baby was doing, ended up going to the OR and there was an area of necrotic bowel with a large perforation in the sigmoid colon and ended up getting a good amount of bowel resected as well. So abdominal ultrasound definitely can be helpful for us, maybe not in the initial diagnosis, but really as babies get worse, a lot of very important information. And to answer your question, yes, that is gas moving in the portal venous system.
Yeah, so they've gone from the, from hepatization of the lung to, I think this one's called what, pneumatization of the I think of the abdomen or of the, of the portal system. So it's good images. I mean, that bottom left on an initial view, just without any other context around it, that initial view could absolutely just be in the stomach, couldn't it? You've got some air, you've got some bits of content, you've got some obviously anechoic fluid. So, but in the context, obviously the upper images, left and right in particular, there on the left, you've got the interloop free fluid, the Tanga sign, you've got, but yeah, definitely good images.
And neck is something we see frequently in the NICU, at least, and worth looking. We do have a lot of radiology help with our abdominal ultrasounds, at least where I'm at. But I think several people probably in Europe actually do their own abdominal ultrasound imaging. Okay. All right, I'm gonna try to get through 2 more cases. If there's enough time for that. But we have a 10-day-old, 35-week infant who actually also presented to our community ED with lethargy, non-bloody, non-bilious vomiting, ill appearing, was transferred from outside ED to our ED with a diagnosis of likely sepsis and an abdominal process, but comes and once they hit our ED is obtunded and has really poor perfusion. So going down, again, the safer algorithm, so doesn't have tamponade, doesn't have a lung-wise, was doing fine, breathing okay, actually was in room air, no abdominal free fluid. But the biggest difference here between Rush and Safer, right, is the inclusion of the cranial ultrasound. And neonates really have a great access point for imaging their brains. And when my fellow put the ultrasound on the fontanelle, this is what they saw. And this is a baby that came through the ED, through our ED. And the only reason why they didn't get to put the ultrasound probably on this baby's head is because that baby came up so quickly to the ICU. And it was quite impressive. This baby ended up having to go to the neurosurgical suite to get a shunt because of how rapidly progressing it was for some reason. And I guess my question for the group is actually, do you guys do head ultrasounds routinely in the ER?
I know of a few people who do may, but not routinely, no. I think some of the people on the call will have been trained kind of a long time ago in their time in neonatology. I know one of my colleagues has done some. I've seen it be done. I've never had formal teaching on this actually. So I guess in PEDD, we might look for skull fracture, and there's even some papers looking at frank bleed, but it's not really something that's in my skill set at the moment. It's something I'd probably like to learn actually to add in, just as that rule in, as that kind of rapid assessment for a patient, much like your own. I don't know if other people on the call have got different experiences.
We do it routinely in the neonatal unit. We neonatal consultants do it, and one of our radiologists also does it. Yeah.
I will say typically we have a very strong neuroradiology group here. So we don't do as much cranial focus on our own, but in an emergency, we will put the probe on the fontanelle ourselves. From a probe selection standpoint, when asked, we do typically use the curvilinear probe when we do our cranial ultrasounds. Now, does that mean you can't use a phase? Not really. I mean, in an emergency, you really could use any, but traditionally we do use the curvilinear probe. Just a quick primer from a cranial ultrasound standpoint, there are 2 typical views. You're not doing a comprehensive. So my neuroradiology folks, they do a comprehensive cranial ultrasound. But for me, I need a really quick look in an emergency, and that usually typically is a coronal view and a sagittal view. Many of my our full comprehensive head ultrasounds include like a transmastoid view as well, but we'll typically just take two looks. And the basic technique is to really image through the anterior fontanelle, both coronal and sagittal planes. Conventionally, the coronal views, the transducer marker is going to be on the patient's right. And for those who do cranial ultrasound here, please feel free to chime in if I get anything wrong. And for sagittal views, you rotate the notch to point towards the baby's nose, to the front of the head. And the first view should be the midline view with the corpus callosum. And then you sweep to the right, midline, then left, and then anterior and posterior as well in the coronal views. So you kind of take a sweep as opposed to a single image. And the main thing about head ultrasound is really you have to be aware of the choroid plexus. It's tricky because while blood should be bright on ultrasound in the head, it's important to know that there's a structure called the choroid plexus. And while nothing should really be brighter than the choroids, if it's concerning for blood, but folks, especially when they're first starting, can actually be fooled by the fact that there is choroid and think that it is blood. So I'll show you a quick image of it. So this is a coronal view, scanning from anterior to posture a little bit. So these are your ventricles here. And I didn't do a good job of staying midline on both sides, but this is all choroid plexus. This is not blood. And then here's the sagittal sweep. So starting in midline, scanning on one side, taking a look, and then scanning back to midline. That's all choroid plexus right there. See that? Up there is choroid plexus. So you might look and say, oh, this is quite bright. Is that blood? And that in this particular image is not blood. Here's a kind of a little still just to kind of re-emphasize that choroid plexus can be quite bright. Typically, when we look at intraventricular hemorrhage in neonates, you know, I think the point of the SAFER is not to diagnose grade 1 hemorrhages. While grade 1 hemorrhages are small bleeds, it really is to identify these big, gigantic, extensive intraventricular hemorrhage that really may change how you approach care and also what you do in terms of stabilization. And I will show you one other image of a baby who actually was quite healthy, went home from the newborn nursery and then represented with just in extremis and actually ended up having E. coli meningitis with empyemas. And no one knew why. Pretty significant ventriculomegaly, and there's actually quite a lot of product in the brain. Yes. Celia, thank you. Yes. Typically a microconvex probe is what we'll use for head ultrasound, and then and even for SAFER, I use the probe that I have. I can actually use a phase for a lot of what I do. Okay, I'm going to go back really quickly to the case in the very beginning because I think it's interesting, and it's a baby that could present to you in your ER, and I will show you an image. This case in particular is one that I just came up with. So tricked you in the very beginning in that this is not a real case, but I did once have a baby in the nursery that I diagnosed with this. So this image, these images are two abdominal images, right and left. I'll leave you with these in terms of like, this is for some novice scanners here. This is your diaphragm, nice and bright. This is the liver, there's kidney, there's the spine, this is the lung up here. And on the left side, no matter how hard I tried, I could not get that diaphragm. And into the lung was quite a bit of contents that don't look like they belong. And then moving on to if you did a, yes, CDH, you're right. So when I did a midline view, so you should see the diaphragm on both sides here. You should see this is the right side, and the left side does not have that diaphragm in this image at all. So it is indeed a CDH. So on X-ray, you would see this. Questions? Maybe have your hand up.
Yeah, Maya, I think this view's amazing. I really like it. You showed me it a few years back and I've talked about it a lot. For people who've either done a little bit, some of my colleagues in PEM, or maybe just for the beginners, are you all right to just unpick what this image is? Because it's a really, really useful view that probably, well, definitely we can only do in neonates, not in any other. Sometimes get it in a 3-year-old, 2-year-old, but yeah, I love this view because it shows you so much normally. Maybe a normal would have been better, but anyway, it's a good view.
Yeah. So for those on the call, if you're interested, so this is a transverse view. Really, if I show on here, you're taking your ultrasound probe and your probe marker is to the right side. And here, typically you see the aorta right here, pulsating. And usually this is the vertebral bodies around here. And then it's really a kind of usually do almost like a subxiphoid transverse view. And then you should be able to see both diaphragms equally when you're spanning towards the diaphragms. And Dave, have you done it in any of your kids or patients?
Yeah, I've done it. You know, sometimes I do it accidentally. So if I've got the curvilinear probe and as you say, I'm subxiphoid, I'm just looking at. It's really good, you know, in like babies who are in the PZD. Again, not expecting that kind of pathology, but it's just nice to be able to see all the way up to the lung bases, see the diaphragm, come back, you know, see kidney. So I was just explaining. I was hoping you would kind of say what you said, and that it should normally be a nice symmetrical view with, you know, equal anatomy on both sides, whereas clearly this image is really grossly abnormal.
Well, I will end by a couple of just very key takeaways, I think. You know, CDH is not on the SAFER framework. So SAFER really is just a framework. It's not a comprehensive assessment, but it's a place to start, especially when sick babies show up. The thing also to remember is that sick babies decompensate quickly. Babies, I feel like, are very resilient until they are not. And so they can actually get sick quite quickly. And I think POCUS can accelerate our care for our babies and patients. Feel free to call for help early. For us, at least, there's always a NICU around. So if you needed us, we're always there. And then POCUS is not the same as resuscitation. So POCUS, we may be helping to diagnose, but we really do have to be treating the patients while we're scanning them often as well. And then specific to the neonates, you know, cold stress is real. Cold stress is really detrimental to some of our babies, especially to my fellow neonatologists on the call. You know how important it is to keep them warm. So warm gel, if you have it. Less pressure sometimes gives you better images. If you're going to image the head, please don't push really hard on the fontanelles. The neonates are small, so a few millimeters do matter, especially when you're doing your procedures. And really never trust a preemie, even if they've been discharged home. You never know what they're going to show up with. I will end just by saying that the Neonatal POCUS Collaborative, there's a QR code where you can kind of go, or neopocuscollab.com. They actually have 2 webinars by the authors of the Crash and Infant Protocol and the SAFER Protocol that you can actually listen to if you're interested. And happy to kind of take questions or talk through anything else. Yes, Tilia has a question. Or
I was
hand
just
raised.
wondering what was the window for the last view you showed us? How do you actually practically do